Hello and good morning, everyone. Welcome to our web show, It's All in Your Head. My name is Angie, and I am here with Dr. Paul Swingle today to talk about the neurotherapeutic treatment of addictions. Before we begin, I would like to tell you a little bit more about Dr. Swingle. Prior to moving to Vancouver, Dr. Paul Swingle was full professor of psychology at the University of Ottawa. A fellow of the Canadian Psychological Association, Dr. Swingle was also a lecturer in psychiatry at Harvard Medical School, an attending psychologist at McLean's Hospital in Boston, where he was also coordinator of the Clinical Psychophysiology Service. Dr. Swingle is a registered psychologist in British Columbia, certified in biofeedback and neurotherapy. His newest book, Biofeedback for the Brain, was published by Rutgers University Press, and it is available at soundhealthproducts.com. During this webcast, you are welcome to send us your questions. I know some people are already doing that, so thank you. We will have 2 formal Q&A breaks to go over these questions, so please do not hesitate to send them to me. You can do that by using the chat box that is located in the control panel. And if we don't have time to answer all of your questions, you can also send them to me via email at angie@swingleclinic.com. Okay, let's get started. Let me welcome Dr. Paul Swingle. Good morning.
Good morning. So we're going to be talking about addictions in the broad sense of that concept, and some of these conditions are extraordinarily difficult for folks to get under control, and there are all kinds of reasons why we get addicted, and many of these conditions, of course, are life-changing. We're going to be talking obviously about the neurological bases for a lot of these conditions. What is it that these substances or activities do that can have a rewarding effect or a pleasuring effect or a quieting effect on us because of our physiological makeup? So we're going to be talking about arousal concepts. We can be addicted to something because we are under-aroused and we need something to arouse us, to give us an increase in mental and physical activity feelings, or the reverse. We can be hyper-aroused, stressed if you prefer, and the substance that we are dependent upon helps us to quiet down. We also have activities that are distracting. So if we are trying to avoid something, we can get involved in something that has that property. And many of these activities aren't necessarily negative in the sense of something like gambling, for example. It may simply be something like work, the workaholic, for example. Obviously, there's an emotional component to most of these things, and a lot of the chemicals and or activities can either have upping or down, that is, arousing or quieting effects. And a lot of them, we want to look at what part of the dimension are we on. Are they properties, that is, the activities or substances, giving rise to pain reduction, or is it something that gives rise to pleasure? So a lot of dimensions to consider as we're working through this. And all of what we're going to be saying, at least in the terms of the neurology of it, is based on what is called the clinical cue. And what that is a set of data that indicates neurological conditions associated with certain symptoms. So we have a huge clinical database of more than 1,400 people, and we've been able to narrow down the areas in the brain that we have to look at in the first instance to be able to determine conditions such as depression, anxiety, poor sleep, and so forth. And a lot of these areas are intimately involved with our predisposition or vulnerability to addictive behavior. And the 5 sites that are associated with the clinical cue, that is the initial intake EEG assessment, electroencephalographic assessment, are the ones shown in red here. CZ or CZ is right in the center of the motor strip. That's the sensory motor cortex, sensation, perception, motor movements. Then the back of the brain associated with many things, but we're particularly interested in its association with stress tolerance, anxiety, and sleep. And then the executive area of the brain right across the frontal strip. And those are locations F3, the left, F4, the right, and FZ or FZ right in the center. So those are the areas we're going to be making reference to as we proceed. Now, this is a set of data associated with a male 13-year-old child, and I know nothing more about this child than age and gender. And these are the data that come out of the clinical cue that I was just describing. Now, those 99 numbers that are sitting there boil down to 22 that can be summarized here. Now, there's a lot in this, but I want to point out a couple things here associated with vulnerability to addiction or dependence, and some issues associated with being able to identify a child or an adult that may be actually using a substance. So first of all, the area circled in red. These are measures that were taken right on top of the head. If you remember, CZ or CZ is sitting right on top of the motor strip. And we have a marker here for attention deficit disorder. Here's a child who has an excess amount of slow frequency in that region in the brain, and that's usually associated with difficulty sustaining focus and attention. But this child has a particularly pernicious form of that characteristic, and you'll notice where it says R theta beta. That's when the child was being cognitively challenged. That is, I asked the child to read. Now you'll notice the ratio gets worse, and when the child's under cognitive challenge, his attention problem becomes more severe. Now, this was first identified by Dr. Fitzsimmons, who was a professor at the University of Alberta in Calgary. And it's a form of ADD that the harder you try, the worse it gets. And what we found, he discovered this 10 or more years ago, and in some circumstances, when you just measure an EEG of a person at rest, you don't see anything. It's only when you challenge them that you see the ADD. Now, the problem with this kind of ADD, if you will, is that the child doesn't get rewarded for effort. The harder they try, the worse it gets. They make heroic efforts at trying to focus and study, and it just leads to failure. So these are the kids that give up. Our prisons are loaded with young males in particular that look like this. Okay. So first of all, I know what to do relative, let's call him Johnny. Johnny's ADD, and Johnny really bonds with me when I describe what I just described to you. I'm the only person on the planet who understood his condition, as he later told me. But the area circled in green. They're my warning signs. So I asked Johnny's mother to leave the room, and to make a long story short, I told Johnny to stop smoking dope, which he in fact was. So the clinical cue did a lot in terms of identifying a condition, B, identifying the nature of condition that makes that child highly vulnerable to giving up and quitting. Third, as you can see here, the association between ADHD and addiction is huge. Alcohol and drug addiction, 50% comorbidity. They're 50% more likely to be cigarette smokers than the general population. There are other conditions here as well, but those are the ones for the purpose of our present discussion are the ones that are of importance. That is, what are the conditions that are comorbid? That is, you have a predisposition to become dependent or addicted. And as you can see, ADHD is a biggie. Now that's the power of the clinical assessment, the neurological assessment. In terms of 6.5 minutes of recording time, we know exactly what this child's condition is, what the problems and challenges are, what his vulnerabilities are, and the fact that there was a high likelihood that he was using cannabis. So what we were just doing there is, this is the area of the brain that it turned out was problematic in terms of the ADD issue with Johnny. And what I noticed was that there was a marked elevation of slow frequency in the back of the brain under certain conditions, much more so than another condition. The contrast indicated cannabis use. And up in this region, I was looking at the alpha peak frequency, as it's called. That is, how fast is a particular waveform, which is associated with brain efficiency, IQ, good immune functioning, and so forth. And I saw that that was compromised. That was the other marker I had for saying to Johnny, lay off the pot. Okay, genetic alcoholic. You know, if you talk to a lot of people in the area of alcoholism, they will simply point out that there's a genetic predisposition for this condition. It's not curable. What you need is lots of support, operations like AA, for example, rehab centers and so forth. And sometimes they use anti-anxiety medication. Naltrexone is one that's popular for use. Dopamine agonists are another thing that are being used. And the reason they have some effect is here, where this is the back of the brain. Now, O1, remember that's the back of the brain, occipital region in the brain. And there's a ratio back there of slow to fast activity. And when that ratio is very low, that is meaning there's too much fast activity, too little slow activity, then the individual has poor stress tolerance, predisposition to anxiety, sleep quality problems, a lot of chatter in the head, a lot of body feelings of unease. And alcohol hits that instantly. And that's why it has such an addictive property for these individuals. It just feels good for everything to quiet down. And that's what alcohol does for these guys. Now, I just showed you a genetic marker for predisposition to alcoholism. It's important to remember that we are not dealing with determinism here. We're dealing with a situation in which we're looking at predispositions and vulnerabilities. And the best example of this, to get an understanding of what we mean here, is to look at identical twin studies. If one twin has schizophrenia, what's the probability that the identical, genetically identical twin will have schizophrenia? Well, it's about 50%. The interesting statistic is 50% will not. Now, the fact that we have a genetic marker for alcoholism doesn't mean that anybody that has a theta-beta ratio, for example, below 0.8 is an alcoholic. No. It means we have a much higher probability of the occurrence of alcoholism under those conditions. Now, a lot of conditions are associated with addiction to legal medications, prescription medications, and this is an example of that. And I like to think of this as a situation in which we have been treating the wrong condition. Here's a 50-year-old male who has a long, long history of depression, 40 years. and he has been addicted, I think it's fair to say, to prescription medications. He's been 30 years under these variety of pharmaceutical cocktails. Okay. Now, I just showed you a marker for the genetic alcoholic, and here we have exactly the same marker, a severe deficiency of the theta-beta ratio in the back of the brain, which this indicates is the marker for very poor stress tolerance, severe anxiety, chatter in the brain, problems with focus, sleep disturbance. Now, it was defined or diagnosed as depression. So he was treated with antidepressants and all kinds of other things. There's no depression marker here, zero. We get an awful lot of people coming in who have these very unsuccessful therapeutic histories of years, decades of treatment for what they have always understood to be depression, and it's not. It's anxiety, if we have to hang a label on it. And this poor fella has it in spades. Remember the area FZ, FZ that we were talking about? Well, underneath that area, there's a subcortical structure referred to as the anterior cingulate gyrus. And in his case, it's extremely hyperactive. So this guy is severely worrywart, to use a technical term, and he's got a condition that's similar to OCD. That is, he gets something on his mind, he can't get it out. So it's not depression, it's a feeling that your life is falling apart and it's hopeless. Now, a lot of people, of course we would refer to that as a feeling of depression and so forth, but neurologically that's not what it is. Neurologically, this is a severe condition of poor stress tolerance, anxiety, inability to shut down and quiet the sympathetic nervous system. And he's got conditions that are exacerbating one another. They're synergic, highly synergic in a negative sense. Now, when we do full brain maps, all 19 sites, then we can see this pictorially. Now, this individual has depression and anxiety. The depression is indicated by elevated activity over on the right side, front side of the brain. That's your marker, that is a marker for one form of depression. On the right side of the brain is markedly more active than the left. And here's that elevated fast frequency in the back of the brain, the one we were just discussing in the previous client. So we see anxiety, sleep problems, and depression, exactly what the person said. So we didn't have to ask him. We look at the data and we can tell the fellow why he's sitting in front of us. Now, severe depression is where you have multiple markers for this. Here we have a situation in which we have a lot of activity on the right side of the brain, fast activity. There's one marker for depression. We also have a lot of slow activity over on the left, meaning that the left is subdued, hypoactive. So we have two markers for depression. We have elevated alpha activity in the front part of the brain. That's a form of ADD, but for our purposes, what it's an indicator of is emotional dysregulation. And then finally, this individual has what we call a trauma. A marker associated with poor stress tolerance up over the sensory motor strip. So here we have a situation in which the individual has two markers for depression, one on each side of the brain, and has a marker for deficient theta-beta processing, so poor stress tolerance, in other words. And in addition, had elevated activity of alpha in this part of the brain, which is an emotional dysregulator.
Thank you, Dr. Swingle. We have a few questions already from the floor. The first one is, what is the relation between brain trauma and addiction?
Traumatic brain injury is highly related to vulnerability to addictive states. Now, there are a lot of reasons for that. One is purely structural, and that is where an individual is being medicated for a particular condition, and in terms of the you're becoming dependent upon the medication. You can have a secondary process in which traumatic brain injury gives rise to emotional dysregulation. You know the data from the National Football League in terms of head injury being associated with elevated levels of aggression and violence. So here we have a situation in which the individual is behaviorally out of control and may be medicated for that kind of condition, or may be self-medicating with alcohol or cannabis or something of that nature to try to quiet himself. And then the third is, since the frontal cortex is almost always implicated in any brain injury because the way the brain sits in the cranial vault, it may have damage on the left side of the brain, meaning that the right's more active than the left, and that can be trigger a neurological predisposition to depressed mood states, resulting in medicating. And in terms of alcohol, individuals who feel that they can't cope because of the head injury, again, have elevated risk factors.
Thank you. The next question is, are there any good addictions?
I'm a workaholic, yes. Yeah, it all depends. You know, you have individuals who they hide in their office, so their relationships fall apart. Is the fact that the individual is doing all of this work and whatever it is he or she is accomplishing is a positive side of it, but the collateral damage associated with it may be negative. So it's always a function of, let's see what consequences are associated with the behavior. Mm-hmm. And I think if you're going to use the term addiction, there's an implication that there's that the substance or the activity is wagging the dog. The tail is wagging the dog. And to that extent, there are likely to be collateral negative effects.
Okay, thank you. And I think we can continue, and then we'll leave the other ones for the rest.
Okay. Now, emotional trauma is highly correlated with predisposition to, or vulnerability, I should say, to addictive behavior. And I've shown this a number of times to folks. This is a EEG tracing at one location on the brain. And if you look at the top white line, that's the raw signal. Now the raw signal can be broken down into its components, how much slow activity is in there, how much alpha activity is in there, and how much fast frequency is in there. So that's broken down either by filters or mathematically with what's called fast Fourier analysis. And this is extracting out the theta from that raw signal. So this is the theta activity, slow frequency, 3 to 7 cycles a second. This is the alpha activity, 8 to 12 cycles a second. And this is the beta activity, 16 to 25 cycles a second. So if you put that into a spectral display, the whole thing is the white line, or white tracing. The theta is running from 3 to 7 cycles a second. That's right in this region right here. And the alpha is 8 to 12, so that's this area right in here. And then the beta is going from 16 to 25, so the area that we're measuring is right in here. Okay. Now, a couple of things we should notice here. One is there's a nice algorithm here in which amplitude is inversely related to frequency. That is, slow frequency has highest strength, highest amplitude. Fast frequency has lowest amplitude. And that's what you expect to see in a normal EEG. And we can get very specific responses. So, for example, this is eyes open, and when I tell the person to close their eyes, that 8 to 12 alpha activity is going to jump. When they close their eyes, you're shutting off the visual cortex, and alpha is going to go up. There it goes. And that's your eyes closed condition, the alpha response, as it's called. It should come up nice and sharply, and it should drop like a rock when the person opens their eyes. And that's a measure of efficiency. We look at that in the elderly to make sure that it's sharp. There it goes. Okay, so there's an eyes open, eyes closed alpha response. This is trauma. Now, again, we're watching that 8 to 12, and what you're going to see is it just has a peculiar look to it. You'll also notice that the spectral analysis is kind of flat relative to the other one. So just by looking at it, I noticed something wrong. This is not a healthy looking EEG. So you can see a little effort to try to get that alpha up there, but it just can't stay. It keeps getting pushed down. This happens to artists with artist block, by the way. Their creative waveform gets blunted by the trauma. Okay, so that's what a trauma looks like, and here's where we look for it in the brain. Again, right over the sensory motor cortex, that's level location CZ, CZ, the one we were talking about earlier. And in the occipital region in the brain, area 01 on the clinical cue that we were looking at previously. And here's what it looks like in the raw data. Here's where I asked the person to close her eyes up at CZ, and that's what we were just looking at before. And you can see it's not going anywhere. And here's the back of the brain actually goes negative. Okay, instead of going up, it goes down. And this is just the summary of it. So instead of it being above 30%, which is what we want, it's minus 35 at the top of the head. And in the back of the brain, we want it above 50, it's minus 10. Okay, so I know instantly that we're likely to be dealing with a situation of a person who's been exposed to severe emotional stressor. Okay. So these individuals are very, very vulnerable to self-medicating behavior. The brain is putting out a lot of energy trying to subdue the emotionality associated with this. And in our outreach program, where we are offering neurotherapy services to homeless individuals in various contexts, inevitably you'll see this. And to quote one caseworker, you know, he said they have predispositions for a variety of things and a bomb dropped in their life. And this is what he meant by that. And that's basically what we see when we treat the homeless. Okay. Now, what about the effect of alcohol on sleep? Way back in my youth, individuals didn't use sleeping pills and all that sort of stuff. They used a nip of brandy. Okay. Now, what will a little nip of brandy do for your sleep? Well, here's a 66-year-old man, and here's the amount of deep wave sleep he has, and here's the amount of REM. Now, what you need is about 2 hours of REM, so he's an hour over. And what you need is about, an hour, 50 minutes to an hour of deep wave sleep. So he's got plenty of deep wave sleep. And he is using alcohol just before he goes to bed. So here's your nip of brandy kind of metaphor. He's sleeping too long. He should only be sleeping 8 hours. And here it's 10 hours and 20 minutes. Okay. Here's again alcohol. Okay, deep wave sleep. A little on the long side, but not much. It takes him 4 minutes to fall asleep and 2 hours and 30 minutes of REM. It's okay. Here again, alcohol, better sleep pattern. I'm sorry, no alcohol. And look what happens to his deep wave sleep. So he's deficient in deep wave sleep. Takes him 25 minutes to fall asleep. No alcohol, 13 minutes of deep, 40 minutes to fall asleep. No alcohol, 17 minutes of deep. So he's deep sleep deprived. And takes him 21 minutes to fall asleep. And he has some alcohol, 3 minutes to fall asleep, 45 minutes of REM. So, you can make an argument here for the potential beneficial effect of alcohol on sleep. Now, what this does is it brings into context the whole concept of how are you using it, why are you using it, are you dependent on it, are you using it excessively, has it become a danger to your health? And I'm not talking about all the nonsense associated with a glass of wine improves your health status. It depends on where those data were collected. And I've looked at this literature pretty substantially, and I don't see any compelling evidence that alcohol has benefits to your well-being. But having said that, on the other side of the coin, moderate use of alcohol doesn't show any serious deleterious effects, and I mean moderate. Okay, what moderate means is 1 glass of wine for a female, 2 glasses of wine for a male, but not every day of the week. Okay? Now, it depends on what our fellow was using here in terms of how much alcohol he was using, but you can clearly see that his sleep was improved. Now, what about neurotherapy? And what neurotherapy is, as I assume all folks listening know, is we measure brain activity, look for anomalous activity in the brain, check with the client to make sure that the anomalous activity is consistent with the symptoms that they report, and then we use neurotherapy to improve the condition of the neurological anomaly. And you recall the spectral analysis that we were looking at before. This is the same one. So these are the data that we're using in actual treatment. The individual is hooked up so that they're watching the brain activity, and we can give them feedback when the brain's doing what we want it to do, and they can use that feedback and to learn how to self-regulate brain activity. With kids, we can set it up so they're playing a video game with their brain. When the brain's doing what we want it to do, icons move on the screen. When it stops doing what we want it to do, the icon stops. So they're playing a video game, Pac-Man and so forth, with their brain. Brain driving is a much more aggressive procedure, and brain driving uses classical conditioning as its treatment metaphor. Classical conditioning, just like Pavlov and his dogs, It was shown in the 1940s at McGill University, my old university, that you can condition brain waves. They showed that you can condition the alpha response using classical conditioning methods, just like Pavlov and his dogs. So here we can deliver lights based on brainwave activity. So we have lights in the periphery of these eyeglass frames. So we can deliver lights based on what the brain is doing. Here's a setup in which we're delivering sound. There are the goggles with the lights. We're also stimulating acupuncture points. This individual has control of the intensity of those lights and sounds so that they're comfortable for her. And here's an individual whose the brain activity is being driven by sound. And this is a brain driving device, so that we plug in what we want to deliver, and based on whether the brain, let's say we're working with amplitude. When the amplitude gets too strong, we turn on lights to shut it down and so forth. Very straightforward procedure. The interesting thing about brain driving is we can use it with very young children. We've used it for treatment of West syndrome, which is a seizure, serious, often fatal seizure disorder with kids as young as 8 months of age. Because you can do it, you don't need, the person does not have to be attentive to the screen, and it's not a volitional procedure. So we can be delivering sounds, for example, to drive the brain while the person's actually engaged in an activity associated with what we're trying to treat. Person having difficulty reading and comprehending information, for example, can be reading while we're doing that brain driving. Now, when we're trying to deal with something like anxiety, here's an example of what we can do. This is the back of the brain at 01, and we're using brain driving to increase that theta-beta ratio. Now, you remember that theta-beta ratio, when it's low, affects the person's ability to tolerate stress. So poor stress tolerance, predisposition to anxiety, poor sleep quality are all associated with deficiency in the theta-beta ratio at the back of the brain. And here's one brain driving treatment of 20 minutes, and there was an increase of 76% in the brainwave, in the theta-beta ratio in the back of the brain. That's in normal range. This was way out of normal range. Now, this is brain driving, so it's a much more aggressive procedure than regular brainwave biofeedback. Now, because it's a classical conditioning method and we're really pushing the brain, it's not going to stay there. It will drift back, but it won't drift back as far as it was. So the baseline moves up. And then typically we stabilize this by having the person do regular brainwave biofeedback. It's a volitional procedure to stabilize that improvement. So if this was an alcoholic, for example, this would be part of the treatment. So we quiet the back of the brain so that the reward property associated with the alcohol is decreased. So we're taking the reward factor out of the alcohol when we do this. Now, this gives you an idea of just how we're getting feedback. Oh, it stopped now. Okay. This gives you an idea of just how powerful medications are in terms of the neurology of the brain. And this is an individual who's been medicated for over 15 years. The present medications are Paxil and Risperdal. Here's the pre-treatment level, and this is in the back of the brain. What I was just showing you in terms of treatment efficacy of brain driving, and her theta-beta ratio at the back of the brain was a markedly deficient 0.61. Remember, we wanted up around 2. after 20 minutes of brain driving, it barely moves. Now, this is using a very aggressive classical conditioning procedure. Okay, so that's what we're up against when we are working with some of the addictions. A person in the addicted or chemically under the influence of the chemical, that state, we're fighting a chemicalized brain. Now, there's a general rule of thumb: you're treating an alcoholic. If they show up drunk, you don't treat them, okay? People on prescription medications are in a different ballgame altogether, because the half-life on these, the person would have to be, medication-free for sometimes a month before you get into a state of increased plasticity in the brain. So there are a huge number of challenges when we're working with these things. What kind of neurotherapy do we do? What kind of psychotherapy do we do? What kind of titration schedules do we do? What kind of cooperation do we have with the person and also the other treaters in the mix, and so forth? That's why treating addiction is a very complicated operation. And neurotherapy is not a standalone procedure for the treatment of these conditions. It must marry with other kinds of therapies in order to be successful. That's why one-size-fits-all franchises, with people with minimal training, not necessarily in neurotherapy, but in any other area of therapy, are not only foolish but dangerous.
Okay, thank you, Dr. Swingle. We have another couple of questions here. Number one, my brother says that as long as your behavior doesn't hurt anyone, it's not an addiction. I think this is nonsense. How can I help him stop? It's gambling, by the way.
Well, here's the whole issue of codependency. He has to acknowledge, understand, and embrace the fact that gambling is, or at least gambling that has any effect, serious effect on finances, etc., is a problem. It cannot be more important to you than it is to him. That's codependency. Then you become part of the problem, and it is extremely difficult. And here, a lot of guidance can be helpful. This is why you have organizations like Al-Anon, for example, which are individuals who have been affected by, for example, alcoholics. The people are not alcoholics themselves, but they live with alcoholics, for example. Now, the only thing that you can sometimes do is force an individual to look at the actual data associated with it. And the fact that there are people beside himself that are seriously and adversely affected by it. This is what the interventions are all about, in which you get people who are related to the person, either in terms of work associates or friends or family, etc., to corral the person, sit them down, and say, these are the facts. Okay. So it's not easy at all, and it's very important to remember that you cannot change his addiction. You can help, you can guide, you can support, but you can't do it. He has to do it.
The next question is, I hear a lot of pros and cons about AA. What do you think?
Bottom line, I feel with all of these things, if it works, great. And I would suggest anybody who has an alcohol problem that you go to a couple of different groups, see if one of the group resonates with you. A lot of people have difficulty with the religious platform of a lot of these organizations, but for example, there are atheists in AA. I forget the acronym that's used, but there are a couple of groups around here. Alcoholics who are also atheists. But in regular AA, there's no requirement of accepting the concept of God, for example. They talk a lot about higher power, and the higher power can be defined in all kinds of ways. But the bottom line, as I say, if it works, great. If it doesn't, find something else.
Perfect. And then finally, how much sobriety should a client have before starting treatment?
Enough to get here. The reason I'm saying that is it's not only the neurotherapy. The whole concept of an individual taking responsibility that I'm going to do something about this, and they show up, and you set some guidelines, rules, and regulations, have a checkup procedure, so that in the first 24, 48 hours, you're guiding the individual into making a commitment to therapy, and then trying to see whether you can get windows of sobriety for the individual to receive treatment. Those sorts of concepts. The notion that if I say you have to have 2 weeks of sobriety, let's say, before you can start, what I've done, I put a huge premium on making sure that you drink within that 14-day period, because the person can always say, my first job is to get 2 weeks of sobriety, then I'll start treatment, okay? So I've set up a condition of failure immediately. But I know, a lot of therapists have just thrown up their hands. If a person doesn't have a month of sobriety, for example, they won't take them at all. I'm quite the reverse,
Okay, thank you. We can continue with the show.
Okay, the contemporary addiction. When my children were small and I didn't know which side of the computer you had up, and turning it on was a major challenge for me, my kids would come home and say, I'm going upstairs to play on the computer. Okay? And I would say, great, because they were learning how to use the computer in this new fancy fandangled thing. And I saw the potential for it in terms of the educational potentials and so forth and so on. It turns out that we really, really have to be careful here, because a huge number of our children, for example, are failing because of internet addiction. Their social skills are being seriously delayed, and internet addiction is an extremely serious problem. There's nothing trivial about it. Parents get hooked in because if they have a problematic child, autistic child, for example, the screens and internet games and so forth, world's greatest babysitter, unbelievable. So the parent is able to get some relief, and the child's addiction is the parent becomes part of the child's addiction. This is a severely addicted 46-year-old male, and one of the patterns I often see here is, first of all, there's a deficiency in the theta-beta ratio in the back of the brain that's associated with poor stress tolerance. So, self-medicating in terms of gaming could have properties associated with quieting and distraction. But here's another one that a lot of people keep picking up, and that is where there's elevated alpha over on the right side of the front part of the brain relative to the left. And that's a marker that's associated with just some interpersonal angst, and it can present itself in a lot of different fashions. Very young children, that's often associated with oppositional behavior. And we see it often in individuals that are socially awkward or have had difficulties in marriage and so forth and so on. And I pick up a pattern, one pattern in which I'm seeing this quite routinely. And these are individuals who interacting with a person over the net protects them from intimate eyeball-to-eyeball contact. And there's an interesting literature developing around that whole concept. It also can have the opposite effect, and that is can delay children's acquiring adequate social development because of a reduction in that arena of learning. This is a 13-year-old child with exactly the same pattern. That elevated alpha over on the right side of the front part of the brain. And for a 13-year-old, these are the back of the brain is a bit low. Okay. Now, Mari Swingle, who is the learning and internet treatment expert at the Swingle Clinic, has done a major research project and has a book coming out on internet addiction. It has found that one of the things, I've been showing you profiles, she also has found dysregulation generally in these individuals. And what she's found is that the individuals who become addicted to internet show more irregularities in brain activity when compared with normative databases as opposed to individuals at lower levels or non-addictive behavioral patterns. So I think a fair summary is that if you have brain dysregulation of any sort, you're more vulnerable, at least in this case, to internet activities. I find a lot of profiles associated with this, but again, one of the major risk factors are children who are brought in for situations like attention deficit disorder, and when you really have a look at it, the problem is internet. And if you try to take it away, they show every one of the aspects of addiction. They'll scream and yell and get angry and get depressed. Now, the prevalence of internet addiction is pretty substantial. These are older data. We have updates on this. But you can see in adolescents, it's about 13%. In South Korea and China, it's at epidemic proportions with rates over 30% in some demographics. And in some of those areas, they've defined it as a national epidemic. And there are actually treatment centers for it. Items on the internet addiction scale, and you just look through all of the activities. Does school or work suffer? Are they defensive or secretive about the activity? You know, kind of like the alcoholic hiding his bottle. Block out thoughts with online use. Okay, so there's your area associated with something like depression, for example, so you can distract yourself. You know, if you listen to an alcoholic talking about sobriety, they say, what am I going to do? My life's going to be boring, empty, and joyless. Bingo. That's exactly what these kids say. Snap or yell, act annoyed if they're interrupted in their activity, their addicted activity, and so forth. So all of these things are very, very consistent with what you find with any addiction. Consequences. When you look at the data, it's substantial. Financial debt, individuals' marriages fall apart, they're fired, they're suspended, they get into huge financial difficulty, social withdrawal, malnutrition. Some generalizations, it's reinforced in children. there's some people talk about a switch of substances. That is, they used to be dope smokers and they shifted to a safer addiction. And comorbid substance disorders are only slightly higher. That's related to this other item where there's kind of like a transfer of one addictive activity from another, so that the substance use drops in some of these circumstances. Okay, group therapies, by the way, have turned out to be quite good for these conditions. So, and the behavioral addictions resemble substance addictions in many of these domains. And those are the ones we've just been talking about, in which you actually get neurobiological changes associated with the physical activity. And all of the subjective phenomenology, the craving, intoxication, withdrawal, anger and so forth, that being disrupted. There's some talk about trying to work with the dopamine system in these conditions, just similar to what you do when you're working with alcoholism and some of the other serious addictions of these highly dangerous chemicals, things like dopamine agonists, for example. Now, if you look at estimates of substance abuse, substance disorders, what is the comorbidity? Gambling has very high comorbidity. The gamblers in alcoholism, for example, or other drugs. Kleptomania, these kinds of conditions associated with skin picking, for example, compulsive sexual behavior, and here's the internet addiction. So if you're looking at addiction and then you look at other behavioral kinds of conditions, this is where this concept of dysregulation is associated with increased vulnerability. Now, it's a hugely interesting issue to try to sort out who goes where. So an individual, why do they end up in gambling and not with alcohol, or gambling with alcohol, or gambling with kleptomania and so forth and so on? We have a condition here of 12 factorial, so can keep workaholics like myself going for a long time trying to sort a lot of this stuff out. But it's fascinating to try to contemplate this. But we come from the other direction, of course. People come in, have a problem with gambling. We look at the neurology of it, check to see what other comorbidities they have, and then get to work on the brain. Naltrexone is one that's being used for the dependencies, and they've had some success with both alcohol, opiate, behavioral addictions, including internet. Now, the interesting thing about this is a dopamine agonist. Now, this has been used for treatment of depression, bipolar, and so forth. There's some research going on in the use of this with the conditions like alcohol and substance abuse. But the interesting thing is one of the side effects of this: compulsive gambling, overeating, hypersexuality, and compulsive shopping. And this manifests in about 14% of the patients, even those without any prior history of these behaviors. This is a fascinating finding. So when you're messing around with dopamine, there's something that is triggering this. And do they have predispositions, never mind about a prior history? So lots to try to figure out here. Final issue: change takes effort. And I'm a great believer in you eliminate the harm, but people that are actually in the trenches working with folks like the homeless, for example, argue that you reduce harm you're making a contribution. And if you can get harm reduction and then try to move to further and further levels of that, getting into harm elimination. And they are proposing programs like this in which they give drinks to alcoholics but on a scheduled basis to try to control the amount. And they're giving them a substantial amount of alcohol. I think it's about 8 drinks a day in terms of trying to reduce, again, harm reduction. So the jury is out on all of these things, but people who are very well intentioned are trying all kinds of things to try to help folks like the homeless. You know, as I said, we have an outreach program in which we are treating the homeless in a variety of different circumstances, and folks are doing these kinds of efforts as well to see whether they can improve the situation of these people where, to quote the caseworker, a bomb is dropped in their life.
Thank you, Dr. Swingle. That was very interesting. And now I'm going to conclude this episode with a few announcements. First of all, for those of you who are interested in learning more about neurotherapy, this book is a great resource. It's called Biofeedback for the Brain. Dr. Swingle is the author, and we'd like to think is the most important book you'll ever read for yourself, your children, and grandchildren. And it is available online at soundhealthproducts.com. We also have the Clinician's Guide, and this is literature for professional therapists. The book will lead you through the procedures of evaluating and treating patients with a wide range of disorders. It is currently under revision, and we have a release date, and we're very excited. It's going to come out in early 2015. If you'd like to purchase a new edition, we will be happy to put you on the wait list. Please email me at angie@swingleclinic.com. At Swingle Clinic, we have a variety of public information services and training workshops for professionals, such as public lectures here in Vancouver, webcasts, which moving forward will be offered through the BFE, continuing education, live online classes, and monthly grand rounds. We also offer different 3-day workshops for professionals. Participants are instructed on every aspect of the setup, recording, and treatment phases so that they can apply these assessments and treatment procedures in their practices. We will have more information on our workshops on our website at swingleclinic.com under events, and you can also email with your inquiries at angie@swingleclinic.com. If you are a professional, Dr. Swingle also offers online training through the Biofeedback Foundation of Europe. You can visit the VFE's website at www.bfe.org to see all of the offerings of Dr. Swingle's webinars and online courses. The professionals who complete the courses can get up to 24 hours of continuing education.